field where it all begins.
Right. So anatomically speaking, the cervix acts as the neck, or I guess the physical gateway between the vaginal canal and the uterine cavity.
Okay, setting the stage.
Exactly. And microscopically, that gateway is divided into two very distinct biological zones.
Yeah.
You have the exocervix, which is the outer portion.
The part facing the vaginal canal, right?
Yeah, exactly. And because it faces that canal, it's lined by tough, non-keratinizing squamous cells. You can sort of think of them as flat, durable pavement stones that are built to handle physical friction.
Makes sense. It needs to be tough.
Right. But then moving inward, you have the endocervix, the inner canal leading up into the uterus. And that area is lined by a completely different type of cell. It's this delicate single layer of tall columnar cells.
And their main job is to secrete mucus, right?
Yeah, exactly.
Yeah.
So you essentially have these two radically different environments colliding.
Like tough, flat pavement stones on the outside, and then these delicate, tall, mucus-secreting pillars on the inside.
It's a stark contrast, and the border where those two environments meet is this highly volatile boundary line called the squamocolumnar junction, or as the texts call it, the transformation zone.
It's a transformation zone. That sounds a bit ominous.
Well, it's just not static. You know, the vaginal environment is naturally acidic, which is a great defense mechanism against bacteria. But those delicate columnar cells of the endocervix, they really cannot survive in acid.
Oh, I see. So they have to adapt.
Exactly. Throughout a person's life, driven by hormonal shifts and that acidic pH, those delicate cells undergo a process called metaplasia. They are literally reprogramming themselves to morph into the tougher squamous cells just to survive that harsh environment.
So because there is so much active cellular turnover and aggressive genetic reprogramming happening right at that junction, it becomes like the ultimate weak point in the fortress.
It really is. It's a highly vulnerable construction site, constantly rebuilding.
And according to the pathology text, that is exactly where the saboteur breaks in. We're talking about human papillomavirus, or HPV. It's a sexually transmitted DNA virus.
Yes, and the Kaplan Review text describes it specifically as a naked icosahedral virus, which is actually a crucial structural detail.
Wait, naked? That sounds vulnerable.
You think so? Right. Calling it a naked virus just means it lacks an outer lipid envelope. You would assume an extra envelope makes a virus stronger, but in biology, a lipid envelope is actually a vulnerability.
Oh, because it's easily destroyed by soaps or detergents?
Exactly, or even just environmental changes. Without that fatty layer, the naked HPV virus is essentially a microscopic armored tank. It is highly resilient, it's difficult to kill, and it's perfectly engineered to survive and infect that vulnerable transformation zone.
But wait, don't many people get HPV? Like, if it's this resilient tank transmitted through skin-to-skin contact, exposure must be incredibly common. Does all HPV lead to cancer?
No, absolutely not. What's fascinating here is that the vast majority of the time, your immune system wins this war before you even realize a battle took place.
Oh, really? It just clears it out?
Yeah, the texts point out that an acute inflammatory response usually eradicates the virus completely. Furthermore, not all HPV strains are armed with the same weapons. DNA sequencing identifies dozens of different strains.
Right. There are low-risk and high-risk types, if I remember the sources correctly.
Exactly. Types 6 and 11 are classified as low risk. They might cause benign condylomas, basically warty growths, but they lack the molecular tools to hijack the cell's core machinery. They very rarely progress to cancer.
Got it. So the real danger requires persistent, prolonged infection by the high-risk types, and the sources explicitly highlight HPV types 16, 18, 31, and 33.
Those are the big ones, yes.
Yeah.
If your immune system fails to clear those specific high-risk strains, they set up a permanent base camp in the transformation zone and execute this brilliant, really insidious molecular sabotage.
Okay, let's talk about that sabotage, because if we use an analogy here, every normal cell has a home security system, right? These tumor suppressor proteins called P53 and RB.
That's a perfect way to describe them. They constantly monitor the cell cycle.
Right, and if a cell's DNA gets damaged, P53 and RB hit the emergency brakes. They halt cellular division to fix the DNA, or they force the cell to self-destruct apoptosis so a tumor can't form.
Exactly. They are the ultimate biological guards.
But the high-risk HPV virus acts like a highly trained team of burglars breaking into that security system. Once it infiltrates the cell, it produces two very specific viral proteins, E6 and E7.
And this is where the hijacking happens.
Right. The E6 protein acts as a hitman that seeks out and destroys your P53 guard. And the E7 protein targets and destroys your ARB guard.
It effectively cuts the alarm wires and removes the emergency brakes entirely.
So the cell can no longer stop abnormal growth, and it loses the ability to self-destruct. That is terrifyingly efficient.
It really is. And once those vital cellular alarms are dismantled, the tissue transitions into what the pathoma text outlines as a slow, disordered march toward malignancy.
They don't just magically turn into a lethal tumor overnight, do they?
No, not at all. They enter an intermediate precancerous state called dysplasia. In the cervix, this is specifically called cervical intraepithelial neoplasia, or CIN.
And under a microscope, pathologists can actually see this viral hijacking in real time, right? They look for this visual hallmark called coilocytic change.
Yes, coilocytes. The infected cells become visibly sick. They develop these massively enlarged, dark, hyperchromatic nuclei.
Because the virus is forcing the cell to just churn out massive amounts of abnormal viral DNA.
Exactly. And there is often a clear, empty halo surrounding that dark nucleus, almost like a moat. When a pathologist sees a coilocyte, They know HPV is taking control of the factory.
And that factory analogy is really useful for understanding how the CIN is graded. Let's imagine the cervical epithelium, the skin layer, rests on this foundational layer called the basement membrane.
Right. Think of the basement membrane as the soil where the stem cells live, constantly dividing and pushing new layers of cells upward to the surface.
So when the high-risk HPV invades, it doesn't just infect the surface, right? It infects those underlying stem cells in the soil.
Yep, the source of the new cells.
Which means every new cell that stem cell pushes upward is a corrupted, mutated copy. It acts like a toxic weed growing from the bottom up.
That's a great visual. So in CIN, or low-grade dysplasia, that mutated weed is just starting to sprout.
Meaning it involves less than 1/3 of the total thickness of the epithelium.
Exactly. Then moving to CIN2, the abnormal growth spreads higher, occupying up to 2/3 of the tissue thickness.
The weed is really taking over the lawn now.
Yeah, and by the time it reaches CIN3, which is considered high-grade dysplasia, the corrupted cells have pushed almost completely to the top, involving slightly less than the entire thickness.
And finally, you reach CIS, or carcinoma in situ, which translates to in its original place. At this stage, the entire thickness of the epithelium is overtaken by these dark, hyperchromatic cells.
Right, from top to bottom.
But there is a crucial boundary that hasn't been crossed yet. The weed has taken over the grass, but it hasn't invaded deeper into the actual earth beneath the soil.
Exactly. It has not breached the basement membrane. And that basement membrane is the absolute dividing line between a highly treatable precancer and a potentially lethal invasive cancer.
Wow. Okay.
But the most vital takeaway from all of these pathology texts regarding this progression is that it is not inevitable. Dysplasia is fundamentally reversible.
Wait, really? It can just go back to normal?
Yes, if the viral stressor is cleared, the tissue can heal. In fact, CIN frequently regresses entirely on its own as the immune system eventually recognizes the invader and clears the field.
Okay, here's where it gets really interesting. Even if the immune system fails to clear the virus, this biological march from infection to CIN, ISU3, and finally carcinoma. In situ, the pathoma text states that this process takes, on average, 10 to 20 years.
2 full decades. It is a remarkably slow-moving pathological train.
And that 20-year window is the exact reason this cancer is so uniquely preventable. It gives medicine 2 decades to intercept the saboteur.
Which is why it's such a tragedy when that window is missed.
Right, because if those 10 to 20 years slip by unnoticed and the dysplasia finally develops the tools to burn through that basement membrane, we enter the deadly territory of invasive carcinoma.
And the clinical reality of invasive cervical carcinoma is incredibly stark. Because of that 20-year timeline, it typically strikes middle-aged women, usually presenting between 40 and 50 years old.
What are the warning signs at that point?
Well, early in the invasive process, it can be entirely asymptomatic, just hiding deep in the pelvis. But as the tumor grows and establishes its own abnormal blood supply, patients typically experience postcoital vaginal bleeding, dyspareunia, which makes intercourse incredibly painful, or a malodorous discharge.
And that discharge is caused by the dying, necrotic tissue of the growing tumor, right?
Unfortunately, yes.
While high-risk HPV is the primary driver for all of this, the sources do list several secondary risk factors that essentially pour gasoline on the fire.
Yes, they absolutely do.
Like, smoking is a massive accelerator for cervical dysplasia. The texts also point to multiple sexual partners and an early age of first intercourse.
Which really just increases the mathematical probability of being exposed to high-risk HPV strains much earlier in life, starting that 20-year clock sooner.
Right. And there's also a documented link to oral contraceptive use in the sources.
Yeah. But if we connect this to the bigger picture, the most critical secondary risk factor is immunodeficiency. We established that a healthy immune system is your primary defense against HPV.
Right, it's what clears the virus initially.
Exactly. So if a patient has a compromised immune system, for example, if they are infected with HIV, they lose that frontline security force. The HPV virus just runs completely unchecked.
So the progression from mild CIN to invasive cancer accelerates.
Dramatically. The biological link is so profound that invasive cervical carcinoma is officially classified as an AIDS-defining illness.
That really highlights the grim reality of what happens when natural defenses are neutralized. But when this cancer does progress, how does it actually become fatal? Like, does it rapidly metastasize to the brain or the liver?
It's actually different from a lot of other aggressive tumors in that way. While it certainly can metastasize to distant lymph nodes, the most common mechanism of death is brutally mechanical and highly localized.
Localized? How so?
Anatomically, the cervix sits immediately behind the bladder. So as these advanced cervical tumors expand, they physically invade forward, pushing straight through the anterior uterine wall and directly into the back of the bladder.
Oh, wow. Which puts it on a direct collision course with the urinary system.
Exactly the problem. The ureters are these delicate tubes that carry urine from your kidneys down into your bladder. As the tumor mass invades the bladder wall, it acts like a concrete dam, just physically obstructing those ureters.
So the urine just backs up.
Yes. The kidneys are constantly filtering blood, producing urine, but suddenly the fluid has nowhere to go. It violently backs up into the kidneys, a condition called hydronephrosis.
That sounds incredibly painful and dangerous.
It is. The kidneys swell under the immense pressure of their own toxic waste like urea and creatinine, and eventually they fail completely. This postural failure, driven entirely by physical obstruction, is the leading cause of death in advanced cases.
Knowing how mechanically devastating that endgame is, it brings us to the most triumphant part of our deep dive today. How did medical science take a disease that was a leading cause of agonizing death and just knock it to the bottom of the list?
And the answer to that relies entirely on exploiting that 10 to 20-year window of dysplasia.
The pap smear, right?
Yes. The Papillomavirus test, universally known as the pap smear, is the intervention that altered the course of medical history here.
It is arguably the most successful screening test ever developed. And the mechanism is elegantly simple. A doctor just uses a small, specialized brush to physically scrape cells right off the surface of that transformation zone.
They are deliberately sampling the exact site of that vulnerable construction zone we discussed earlier.
Right. And then those scraped cells are smeared onto a slide and examined under a microscope. What exactly are they looking for?
Well, the pathologists are hunting for those precise coilocytic changes. They are scanning the slide for cells with those massive hyperchromatic dark nuclei and that characteristic clear halo.
So, by performing this physical sweep routinely, and guidelines generally suggest starting at age 21, doctors can spot the corrupted stem cells when they are merely at the CIN A2 or 3 stage.
Exactly. They can physically see the precancer, and the physician can step in to freeze or excise that tiny patch of tissue long before it ever has the chance to breach the basement membrane.
You are literally freezing a cancer before it legally becomes a cancer.
It's preventative medicine at its absolute best. The texts are definitive on this point. Women who develop invasive cervical cancer usually have not undergone routine screening. The system works flawlessly, provided you actively participate in it.
However, we do need to point out the biological limitations of the test. It is a physical scrape, which means human error and anatomical quirks come into play.
Right. You can definitely have false negatives purely from inadequate sampling. If the doctor's brush misses the exact microscopic millimeter where the dysplasia is developing, the test will come back looking perfectly normal.
And there's another limitation, right? The pap smear is exceptionally good at catching squamous cell carcinoma, which arises from those flat, surface-level pavement cells and makes up about 80% of all cases.
Right, but its efficacy plummets when dealing with adenocarcinoma.
Because adenocarcinomas arise from those delicate mucus-secreting columnar cells located deeper up inside the endocervical canal.
Exactly. They are basically hiding in a cave, making them much harder for that surface brush to reach and scrape effectively.
And they account for roughly 15% of cases. The pathology texts note a pretty sobering reality. Despite the widespread success of pap smears, the incidence of adenocarcinoma hasn't decreased significantly.
Yeah, the screening tool is fundamentally optimized for the exterior surface, not the inner canal.
Which perfectly sets the stage for the second miracle of modern intervention, the vaccine. If the pap smear is a security camera designed to catch the saboteur in the act, the vaccine is designed to bolt the front door so the saboteur can never enter the building in the first place.
I love that analogy. And the medical sources specifically highlight the quadrivalent vaccine.
Quadrivalent meaning it targets 4 very specific strains of the virus, right?
Yes, it generates neutralizing antibodies against HPV types 6 and 11, which protects the patient against those benign warty growths. And crucially, it also generates antibodies against types 16 and 18.
Putting a massive dent in the high-risk strains that drive CIN and invasive carcinoma.
Exactly.
Okay, so what does this all mean? Let's play devil's advocate for a second. If I am fully vaccinated, if I got the shots and my immune system is actively circulating these neutralizing antibodies, I've effectively locked the doors. Can I just throw away the key and skip the incredibly uncomfortable invasive pap smears?
I have to push back on that assumption heavily, and the medical texts do as well. Relying solely on the vaccine creates a very dangerous false sense of security.
Oh, really? Why is that?
Well, first, Pathoma notes that the robust protection from the vaccine lasts for approximately 5 years, meaning it's not an invincible lifelong shield without subsequent boosters.
Right, that makes sense.
But more importantly, you have to look at the mathematical coverage. The vaccine effectively targets types 16 and 18. But what about the other high-risk strains we identified earlier?
The blind spots, types 31 and 33.
Right. This raises an important question about how we view total immunity. The quadrivalent vaccine does not cover every single high-risk strain of HPV in existence.
So because of that limited coverage, you are still biologically vulnerable to other viral variants that can initiate that exact same 20-year march of dysplasia.
Exactly. Therefore, the texts emphatically state that routine pap smears remain absolutely necessary, even for vaccinated individuals.
It's a mandatory 2-part defense system. You need the locked door of the vaccine to keep the majority of the burglars out, but you absolutely still need the security camera of the pap smear to catch the ones who find a side window.
That is a phenomenal way to conceptualize the defense strategy.
Okay, let's wrap this up and summarize